Healthcare and daily living should be universal, equitable, and evidence driven. But the data that guides our systems often tell an incomplete story. When entire communities are underrepresented in clinical research, real world evidence, and health tech datasets, inequities become baked into the very tools meant to improve care. In this bonus track to our series on medical affairs' role in healthcare equity, we explore how gaps in data lead to gaps in access, outcomes, and trust. Let's start with female crash test dummies. It wasn't until 1996 that the NHTSA introduced a female version of the crash test dummy. But even then, it was just a scaled down version of the male crash test dummy. In the 2000s, academic groups in Sweden and the United States began developing more anatomically accurate female models, accounting for differences in bone density, muscle mass, and pelvic structure. 2012, Swedish researchers at Chalmers University of Technology created EvaRID, a virtual average female rear impact dummy to study whiplash injuries. It wasn't until 2018 to the present that digital human body models that represent pregnant women and diverse body sizes are in use in research, but not yet standardized for regulatory testing in 2025. The consequence is research from the Insurance Institute for Highway Safety, IIHS, found that even with modern safety systems, women in frontal crashes are 3 times as likely as men to experience moderate injury, like broken bones and concussions, and twice as likely to suffer serious injury, like collapsed lung, traumatic brain injury, when using the same crash-worthiness environment. According to Consumer Reports and research from the National Highway Traffic Safety Administration, NHTSA, a female driver or front seat passenger wearing a seatbelt is about 17% more likely than a male counterpart in a comparable crash to be killed. There are many other examples of data in science and healthcare biases against females. For example, in some cities, like Karlskoga, Sweden, road crews clear snow from main roads before sidewalks, assuming commuters drove cars. Yet women walk more often, combining childcare, errands, public transport. When the city switched to clearing sidewalks first, hospital admissions for fall injuries dropped, saving money and reducing harm. Early speech recognition systems were 70% more accurate for male voices. Default smartphone sizes of 5.5 inches plus fit men's hands more comfortably, leading to more frequent drops and wrist strain among women. Phones also barely fit into women's clothing pockets because tech is designed from male body assumptions. VR systems were initially calibrated using male interpupillary distance and height data. Women reported higher rates of motion sickness and nausea because of this calibration gap. Transit systems are typically optimized for home, work, commutes, linear twice-a-day trips, while women's travel patterns are more complex. Trip chaining, including school, elder care, groceries, work. Ignoring these patterns leads to underfunded local routes and longer daily travel times for women. Equal floor space for men's and women's toilets does not equal capacity. Women take longer due to voiding position, clothing, menstruation, childcare, and pregnancy. Yet facilities rarely account for this, leading to persistent longer lines in women's rooms. Safety gear, for example, bulletproof vests, hazmat suits, and lab coats, are typically sized for male frames. Women report gaps, restricted mobility, and exposure risks, sometimes stuffing gear with newspapers to make it fit. When women entered the astronaut corps in 1978, the equipment was retrofitted but not redesigned. Space suits, called extravehicular mobility units, or EMUs, were built in a limited range of sizes, and the smallest still assumed a male torso shape. Some early female astronauts reported issues with oversized gloves, restricted arm movement, and difficulty reaching controls, leading to fatigue and safety risks. The issue wasn't simply size, but proportion. Women generally have narrower shoulders, shorter torsos, and different hip to waist ratios, all of which affect suit articulation and comfort. A famous recent example came in 2019 when NASA planned the first all-female spacewalk, but had to cancel it temporarily because only one medium-sized torso piece was available. Both astronauts, Christina Koch and Anne McClain, needed that same size. The cancellation heightened how, even in the 21st century, equipment availability, not capability, limited women's participation. Let's move on to biases and data and healthcare in people of color. In 2015, it was found that soap dispensers in a Marriott hotel in Atlanta were unable to sense an African-American person's hand. Soap dispensers like this use near-infrared technology, which sends out invisible light from an infrared LED bulb for hands to reflect the light back to a sensor. The reason the soap dispenser doesn't foam out all day is that the hand acts to more or less bounce back the light and close the circuit. This example points to a failure to test a product with people who have a range of skin colors. 13% of Americans are Black, 5% of trial participants are Black. 19% of Americans are Hispanic, 6% of trial participants are Hispanic. 80% of the genome-wide assembly study, the GWAS, comes from people with EU ancestry. Clinical algorithms that adjust for race, for example, kidney function, EGFR, or lung capacity, assume biological differences rather than social context. A 2020 New England Journal of Medicine analysis found thousands of Black patients might have qualified earlier for life-saving interventions if that race adjustment had not been used. Pulse oximeters are calibrated mostly on light-skinned participants. Pulse oximeters overestimate oxygen saturation in Black and Hispanic patients, leading to delayed or missed hypoxia diagnoses. Disaggregated data on race, ethnicity, and social factors in pregnancy outcomes have led to 3 to 4 times more deaths in Black women due to pregnancy-related causes versus white women. The CDC's Maternal Mortality Review Committee found that over 80% of pregnancy-related deaths were preventable. 80% of pregnancy-related deaths were preventable, but target interventions lag because of incomplete data on race and structural contributors. Most pharmacokinetic models are derived from white male populations, so people of color may metabolize certain drugs differently, for example, warfarin, codeine, or clopidogrel, drugs whose PK makes a difference in side effects and efficacy. Most dermatology textbooks and image libraries show light skin tones. Providers therefore have less experience recognizing conditions like melanoma, Lyme disease, or identifying rashes. In major US cardiovascular trials between 2000 and 2019, Black participants represented only 4% of enrollees, and Hispanic participants about 11%, despite cardiovascular disease being the leading cause of death in these populations. A 2022 JAMA analysis showed that most heart failure and lipid-lowering drug trials recruited predominantly white participants, even when minority populations bore higher disease burden. In cancer drug trials submitted to the FDA from 2008 to 2018, only 4% of participants were Black and 3% were Hispanic, even though cancer incidence and mortality are disproportionately higher in these groups. Clinical trials for melanoma and breast cancer often heavily overrepresent white women. For example, less than 2% of genetic data used in early breast cancer research came from women of African ancestry. Despite type 2 diabetes disproportionately affecting Native American, Black, and Hispanic populations, these groups make up less than 10% of participants in major type 2 diabetes trials. 2 examples include SGLT2 and GLP-1 studies. Black Americans are twice as likely, and Hispanic Americans are 1.5 times as likely to develop Alzheimer's disease compared with white Americans. Yet they represent fewer than 5% of participants in Alzheimer's clinical trials. Consequences of underrepresentation go beyond lacking critically important data. It results in justified mistrust of the medical field by people of color and other underrepresented populations. Let's talk about the underrepresentation of obesity in clinical trials and in healthcare. Individuals with obesity are often excluded from trials due to a BMI restriction, so safety, metabolism, dosing data are not studied, despite BMI being a poor indicator of health or even of size. BMI is problematic because it was never designed as a health measure. Go check out the other video on BMI for more details on this. BMI doesn't distinguish fat from muscle, bone, or water. BMI is biased by sex, race, and ethnicity. BMI correlates poorly with actual health outcomes. BMI perpetuates stigma and misdirects care. For more information or how to combat this bias in our clinical trials, head over to LMA's series on medical affairs and healthcare equity.